This is one of my favorite topics, which is the PrEP, the pre-exposure prophylaxis. This is my disclosures, and I'm going to cover all these points. First of all, I'm going to do just a brief review about the PrEP, what we know about PrEP. Then we'll try to answer this question. Could we have better options for PrEP? Could we improve? And I'm going to talk about the long-acting HIV drugs for PrEP and to review the evidence. And then we'll see the pros and cons of this new kind of drugs for PrEP. As a background, well, we know that the prevention based on ARV and antiretroviral drugs has become a cornerstone of HIV prevention, either through the treatment as prevention or the post-exposure prophylaxis, or with the pre-exposure prophylaxis, the PrEP. So we know that the PrEP works, and what works for PrEP? There are several clinical trials showing that the PrEP works in different groups of population. The first studies were implemented among MSM, the first one, and the big one, the IPREX study, show protection of the Truvada, the tenofovir and entrectinib. As you can see, I'm not going to review all these studies. It's just a table, but no, I'm not going to go through all these studies. But to show that from 2010, we know that there are drugs, antiretroviral drugs, which work for preventing HIV, and also in heterosexual and men and women. In women, well, there are some studies. Actually, there are two studies which showed no protection, and this was related to the adherence. Was in these women, especially among young women, the adherence was not good, and the HIV reduction of the incidence reduction was was very low. And also, we have a study implemented among people who inject drugs, and also we've seen the protection in this population, in this group of population. As you can see, the first studies were implemented among MSM, and there are three kinds of studies. The IPREX, they compared the Truvada versus placebo. And although you see that the overall protection was 44%, when they look at the tenofovir TDF levels, they observe that the reduction of incidence was higher than 90%. There are two European studies. One is the PROUD, and another one is the Hypergay. And the difference is that in the PROUD study, they compare there was an arm with no drugs, no medication, no treatment, and another one with Truvada. And in the Hypergay study, what they used was what is called the PrEP on demand. That means that they were not taking a pill every day, but only when they were going to have sex, which means that they have to plan in advance when they were going to have sex. Then they had to take 2 pills between 2 and 24 hours before having sex, then 1 pill 24 hours later, and another one 48 hours later. The efficacy of this modality was the same that in the PROUD study, which is 86% of HIV, of the reduction of the HIV incidence. This table shows that the efficacy is related to adherence, as we saw before in the studies implemented among women. You can see the VOICE and the FEMPrEP, the two studies at the bottom of the table, where the protection was very low. So I'm not going to spend more time on that. What about on real world? Also, we've seen the results of the clinical trials, but are the same do we have the same results in real world? There are different, we have more and more evidence, and this is one of the studies published recently, and it's data from the States, from California, from the Kaiser Permanente, and they have follow up almost 5,000 MSM, and what they have seen is in this period of time between 2012 and 2017, so all these as I said before, mainly MSM and transgender women on PrEP taking Truvada on a daily basis, and no any new infection detected. So these results are even better than in any of the clinical trials. So we know that the oral PrEP works, but can we have better options for PrEP? And the answer is yes, probably yes. And now I'm going to see which could be other options for the PrEP. And these options are the long-acting HIV drugs for PrEP. We have I'm going to focus on the long-acting integrase inhibitors, but there are some. Maybe in the future we could have more. I'm going to focus, as I said, on the rilpivirine and the cabotegravir, the long-acting formulation for cabotegravir. But other candidates could be also the MK-8591, which is a nucleoside, and it seems that one dose once a week could be enough for protecting or for the prevention. And also there is a capsid inhibitor which could be administered every 10 weeks. And antibodies, both the monoclonal antibodies, there are some studies. One of these is with the PRO 140 also, which could be administered every 12 weeks. And the mechanism of action is different, as you can see, but these studies are still on. We have more data on the integrase inhibitors, and as I said before, I'm going to focus on that. I'm not going to talk about implantable PrEP because Dr. Beck is going to talk about that this afternoon, and he's going to do a wonderful presentation, I'm sure. So when we talk about long-acting antiretrovirals, what should we expect? First, that we would like them to be administered with an infrequent dosing. That means every 2 or 3 months. Also, we would ask for a small volume of injection, let's say less than 4 ml, with a minimal PK tail, we'll see why, and also a high barrier, genetic barrier, and this morning we have talked a lot about that, and also with minimal side effects, adverse effects, and also we would ask for a stable formulation which doesn't require the cold chain. And do we have? Yes, we have. I'm going to just to show you this study. It's a phase 2 study with the rilpivirine, a long-acting rilpivirine formulation. These results were presented at the EAS conference. And well, it's just phase 2, and they with rilpivirine, long-acting rilpivirine formulation among women, 136 women, and they observed that this formulation was safe, well tolerated, and was acceptable for this population of women. As a phase 2 study, there is no. They studied just these components. We have much more information about long-acting cabotegravir. These are the clinical trials implemented on cabotegravir. We'll see this more in detail. The first one is the HPTN 077. It's a phase 2 clinical trial with long-acting cabotegravir, and this was implemented among men and women at low risk of infection. This is still ongoing, but it's going to be complete by now. And these results were presented at the last year IS. Well, just to resume, this is the design. There were two groups of participants. One of them received an injection of cabotegravir of 800 milligrams every 12 weeks, and another arm received placebo, and the other arm received 600 milligrams of cabotegravir, and another group received the placebo. I like to highlight that before they received the injection, they went through an oral phase, which means that they received the cabotegravir orally for a period, and then after that, if the tolerance was okay and no adverse events, no serious adverse events detected, then went through the injection phase. The results, as you can see, the adverse events were similar in both groups, except for the injection site pain, which was higher in the participants receiving the cabotegravir, as expected, and also the headaches. In this case, the frequency of these adverse events were higher, but the rest were similar. And from this slide, I would like to highlight that there was a seroconversion in the group of participants receiving the cabotegravir, but as you can see, this seroconversion was detected at week 77, which is 48 weeks after the last injection, which means that probably the levels of cabotegravir were not enough to protect. And as a summary, the investigators of this study said they conclude that the cabotegravir was well tolerated, and just the injection site reactions were more common, more frequent, but only in one case this was a discontinuation of the study drug of the cabotegravir. And also the 600 milligrams also met the PK, the pre-specified PK target. Another phase 2 study. In this study, we are going to see more about sectability of the cabotegravir, and it was implemented on men and with low risk of HIV infection. The design is similar to the previous one. So after an oral phase, they received the injection of cabotegravir, in this case 800 milligrams every 12 weeks, and another group received a placebo injection, and after that it was a follow-up period. I'm going to comment some of the results. In terms of pharmacokinetics, they observed that the cabotegravir long-acting absorption was faster than expected, but the concentrations were lower than expected, which means that probably the injection every 12 weeks couldn't be enough, and it should be administered every 8 weeks. There were also, in this case, two seroconversions, one in the placebo group and another one in the cabotegravir group, but the same. The seroconversion was detected after the final injection, when no cabotegravir was detected in this participant. No? Regarding the adverse events, as I said before, mainly the pain in the injection site was the main adverse event. And when they were asked about the satisfaction or if they had pain. They said in the placebo group, most of them didn't experience any pain, but in the cabotegravir group, there were more participants reporting pain as expected. But it's a little bit amazing because when we're asked about the satisfaction with the study medication, even having had pain, the satisfaction was quite high. As you can see, in the placebo group was 100%, but in the cabotegravir group was almost 80%, even having experienced some pain. No? And when they were asked about the satisfaction and whether they would be willing to continue with the study, most of them, even on the cabotegravir group, said that yes, they would continue with the medication study, with the cabotegravir in this case, or the placebo. And this is interesting because in this study, in the same study, in the CLARE, they did a sub-study, it was a qualitative study, so they asked to some of the participants and the providers about satisfaction, about different items, and most of them said that even having had some pain and some adverse event, they were satisfied with the medication, with the long-acting cabotegravir, and most of them said that they feel some kind of peace of mind because they didn't need to be worried about taking the pill every day. So if they got the injection every 8 or 12 weeks and they just forget about the medication, and as I said before, they express this peace of mind. No? And also, they said that living in a city like San Francisco, where there is a culture where MSM are expected to be on PrEP, as to be seen as safe sexual partners. This have changed a little bit because at the beginning, people on PrEP sometimes could be stigmatized because they were supposed to be more promiscuous or more sexually active. But now it changed, and in fact, in many profiles of these apps for social apps, you can write in your profile that you are on PrEP, which means that you are a sex, or you are supposed to be a safe sex partner. And I like this sentence from two of the participants. One say that he would recommend to do the injectable PrEP because he has not to worry about missing some doses. And this one says that also he likes the injectable PrEP because he doesn't need to plan in advance the sex. He says sex can happen at any time, so I want to be ready for sex at any time. And taking or when I'm on injectable PrEP, I know that I can do that. And before to keep on my presentation, I like to do a quick survey. I would like to ask you if you were on PrEP, which option would you prefer? The oral PrEP, which means taking one pill of Truvada every day, or an injection every 2 months. So please raise your hand who would prefer to take the daily pill every day. Okay. And please raise your hands those who would prefer an injection every 2 months. Yeah. Well, interesting. I see that the majority of you preferred an injection. I guess that you are this kind of people who like to be ready for action, always ready for action. Yeah, congratulations. And I'm going just to finish the clinical trials. I don't want to to talk only about clinical trials. This is a phase 3 study with cabotegravir. And I'm going to highlight the difference. This study is implemented on high-risk population, which means MSM and transgender women. And the difference in the design is that they are not comparing cabotegravir with placebo, because it wouldn't be ethical. Because, as I said before, it's a high-risk population. We cannot implement a study with placebo anymore. So in this case, they compare the long-acting injectable cabotegravir with the Truvada. And another important point is that after the injection phase have finished, they give Truvada to both groups, because when they stop with the injection, there is a period, as the pharmacokinetic scale, where the concentrations of cabotegravir could be low, and if that participant become infected, then there would be a high risk for development of resistance. The design is like this, just injection versus cabotegravir versus Truvada. I'm not going to spend a lot of time on that. And another phase 3 study is the HPTN-084. The difference is that this is implemented among women, 3,200 women. The previous one is 4,500 men and transgender women, which it's quite a big study, both of them, and the same design, comparing the cabotegravir with the Truvada. And just to finish, let me review the pros and cons of these new drugs for PrEP. Starting with the cons. If a person receives a long-acting cabotegravir or rilpivirine or drug, then he has or she has some adverse event, it should be difficult to manage this adverse event, because as you have seen before, the drug can persist for months in their body. No? So this could be a problem. And as we can see, a very common effect is the injection site reaction pain. Most of them experience that pain, and in other studies for HIV, like the latest study, this is a complaint, and some patients say that they spend 2 or 3 days with pain. They can work, they can keep on doing work, they work and their normal life, but they complain anyway. And also, as I said before, there would be a potential risk for development of resistances, especially when they stop the medication, the injection, and during this pharmacokinetic tail. And also could be a barrier if we have to give the injectable PrEP only at hospitals. This could be a barrier for them. No, so it's important to see where this PrEP could be delivered, at the hospital, at the health center. If we look at this survey, which was the Flash PrEP, was implemented in Europe, and when these almost 16,000 MSM were asked about where they would prefer to receive the PrEP, 85% said that they would like to receive PrEP in a health center or in a community center, but not in a hospital. Let's go to the pros, and we would expect a bit better adherence with the long-acting injectables, especially in some situations like in chemsex. You know that when there are people who use drugs for sex, they can spend hours and even days in what they call parties or chill outs, or taking drugs and having sex. In these situations, the adherence can be difficult. And also some people say that taking pills, other people or their family or their friends could think that they are already infected if they take the Truvada, or that they are much more promiscuous, or so they could feel some kind of a stigma. Whereas if they get an injection every 2 months, all this could be overcome. No? And effectiveness, it's a there is a study recently published. It's a modeling study, but it shows that the long-acting injectable could be more effective than the oral PrEP. According to this study, to this modeling study, the reduction of HIV incidence could be with long-acting PrEP could be 44% versus 33% in those taking the oral PrEP. Mm-hmm. And another pros is the satisfaction. We've seen that there is a high satisfaction of people taking the long-acting PrEP in spite of these inject site reactions. We know that many people would prefer, as most of you, the injectables, and we have some data on that. There are some studies. One of these was implemented in the States, the United States, and it's an online survey among more than 4,600 respondents, and almost 50% said that they would prefer an injection versus 17% who would prefer a daily pill. And also, according to this study, the long-acting PrEP could help to reduce these social disparities in HIV transmission. We know that there are social disparities, and there are some groups of population where they have more incidence of HIV. And in this study, they observed that who preferred the long-acting injectables were younger, were Black or Hispanic, and were people more at risk with more condom-less anal sex, and also with lower education level. So maybe with oral PrEP, we are not able to cover all this population, but with long-acting injectables, we would be able to do. And of course, we should expect less toxicity with the integrase inhibitors. As a conclusions, we know that the daily oral PrEP has been proven effective, also in real world, but the efficacy it's strongly related to adherence, and the long-acting injectable drugs may overcome barriers to adherence, and also the long-acting injectable could be preferred by many potential users, and cabotegravir is a potent integrase inhibitor that formulated as a long-acting injectable is a promising option for PrEP. We have to wait for the results of the phase 3 studies, but as I said, it seems that it could be a promising option. And muito obrigado por su atención. Gracias.